This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Welcome to Fellows Conference. Today we have Dr. Hiroki Ueyama, who is one of our graduating fellows. Hiroki came to us from Mount Sinai Beth Israel in New York. He joined our clinical investigator track where he worked with Dr. Babalieros for 2 years and then started his clinical time. And he is going to be going on to interventional fellowship next year in Boston. Today, he's going to be talking to us about something that I think we all think about when we're on echo, mitral annular calcification. So we'll be very interested to see what he has to say about it. Thanks, Hiroki.
Okay, thank you very much for joining. Yeah, today I will discuss this topic, microannular calcification or MAC, which is a clinical entity that has transitioned from being viewed as like a benign incidental finding of aging to a more of a complex progressive disease process. And MAC presents significant diagnostic and therapeutic challenges in modern structural cardiology. And at Emory, we receive a lot of patients with MAC for structural intervention. So I will review the natural history of this condition, the evaluation process and its challenges, and emerging interventional landscapes. So I have no disclosures. So our objectives are to first explain the pathophysiology and natural history of MAC and its progression to mitral valve dysfunction. Second, we will characterize the multimodality imaging features and diagnostic challenges associated with grading MAC-related mitral stenosis and regurgitation. And then finally, we'll discuss the current management strategies and the technical challenges encountered when treating patients with significant MAC-related mitral valve disease. And I'll start with a case that illustrates the clinical complexity of this patient population. The patient I saw was a 79-year-old Caucasian female who presented to outside hospital with 6 months of progressive dyspnea and was admitted for acute decompensated heart failure. An echocardiogram was done there, which I'll show in the next few slides, but raised concern that her valvular disease is causing her symptoms. So she was transferred to Emory for consideration for intervention. And she had a notable valvular history with a known mitral stenosis and regurgitation and aortic stenosis and regurgitation. She was evaluated by her local cardiologist 2 years ago, which from the records mentioned that they were initially suspecting rheumatic in etiology and actually underwent sternotomy 2 years ago. However, during the operation, she was noted to have a mitral annular calcification, and it was thought to be too severe, prohibiting a safe procedure. And the surgery was actually aborted at that time. And aortic stenosis at that time was thought to be only moderate, and no intervention was done. Unfortunately, she developed complete heart block post-op, had a dual chamber pacemaker implanted, and then she was offered to be referred to Emory for consideration for transcatheter options, but she was uninterested at that time. And otherwise, she has severe pulmonary hypertension, which was thought to be group 2, atrial fibrillation, atrial flutter with ablations, hypertension, hyperlipidemia, diabetes, CKD3, and obesity. Excuse me. These are some echo images that was obtained when she was transferred here. Here you can appreciate preserved LVEF, somewhat small LV with severely dilated LA. Notably, there's significant calcification on the mitral annulus, extending it into the leaflet, as well as calcific aortic valve leaflet with restricted motion. On the Doppler image here, you can appreciate some turbulence across the mitral valve, as well as degree of AI. Here in the short axis view, we can see aortic valve with severely calcified and restricted motion. Another short axis view showing flattening of septum, suggesting high pressure in the right side of the heart. And then the four chamber view is showing again a notable MAC extending extensively into leaflets and subvalvular apparatus. And also the counter of RV and RA, it's a little bit not well seen, but it looks generally dilated. And this is a Doppler focus on the mitral valve, again showing aliasing of the Doppler during diastole, suggesting some degree of mitral stenosis, and some degree of MR, which cannot be well evaluated here because of acoustic shadowing. These are some measurements. Mean transmitral gradient was 13 with heart rate in the 80s. The limit, the limitation of the pressure halftime in MAC related to MS, I will touch base later, but nevertheless, the pressure halftime was 146, and the calculated mean mitral valve area by pressure halftime was 1.5. The mitral valve area calculated by continuity equation was 0.9. And then Doppler across the aortic valve was not well captured here, but the peak velocity was 3.1 and the mean gradient was 21 and significantly elevated RV systolic pressure. These are some TEE measurements and images. Again, we can see a severe MAC extending into the leaflet and subvalvular apparatus with significant aliasing during diastole and mitral regurgitation. This is a great view of 3D, again showing mitral annular calcification and leaflet calcification and restricted leaflet motion, and then a Doppler again demonstrating a significant amount of MR. You can also appreciate significant amount of AI, aortic valve being calcified, and a severe TR as well. And this is the multiplanar reconstruction of the mitral valve with planimetry of mitral valve area showing 1.5. And then finally, the Doppler across the aortic valve was better captured with the TE here with a peak velocity of 4.2 and the mean gradient of 37. This is the CT scan, which showed more of a 270-degree calcification at the annulus and some extending into the intramitral leaflet. And there's this virtual valve implanted in the annulus, but you can see that the annulus is pretty large, and largest transcatheter heart valve that's virtually implanted here is not quite fitting the geometry here. So briefly going through her unfortunate course upon her transfer to Emory, she was still notably very volume overloaded. She was attempted to aggressively diurese, but her volume status did not improve, and her renal function worsened to the point that she required initiation of CRRT and transfer to CCU. The course was also complicated by mixed shock picture from urosepsis as well as cardiogenic shock from lack of forward flow from the valvular disease, and she required escalating doses of vasopressors and remained in shock despite a broad spectrum antibiotics. In terms of her valvular intervention options, the CT analysis showed that she had a very large mitral annulus and high risk of LVOT obstruction that excluded her from any currently available transcatheter mitral valve replacement options. And eventually, after discussing with the patient and the family, it was decided to try pursuing TAVR for the aortic stenosis and intravascular lithotripsy of MAC-MS with the hopes to improve the hemodynamics. The procedure itself went well, but she continued to have significant high pressure requirements, and ultimately it was determined to transition for comfort care. And I think this case really illustrated all the challenges that we face with mitral annular calcification at every stage of the management, including its diagnosis, the surgical complexity, current limitations in transcatheter treatments, and difficulty in determining the optimal timing of intervention, and overall very poor prognosis and natural history. And with that, I would like to kind of start by what is MAC? So MAC is a chronic progressive disease process that is characterized by calcium deposition on the fibrous skeleton of the mitral annulus. And it was first described in autopsy as an incidental finding, and interestingly, in a case of complete heart block in 1908. And then in 1910, this calcific disease on the mitral annulus was formally recognized as a distinct clinical entity. And this was when it was first described that the posterior portion of the mitral annulus tends to be more extensively involved. And this image represents one of the earliest published autopsy photograph of MAC on mitral annulus. And in the 1970s, the advent of echocardiography allowed MAC to be identified within a living human body, then only compared to, since then, it was post-mortem findings. And although it was initially considered largely incidental finding, studies from 1980s to the 2000s has established that MAC is actually associated with adverse cardiovascular events and mitral valve dysfunction. From a management standpoint, severe MAC has long been recognized to pose significant challenges for surgery. However, beginning in the 2010s, um, reports of transcatheter mitral valve replacement in the setting of MAC has emerged, which led to current growing interest in MAC-related mitral valve disease as a potential intervenable condition in the era of transcatheter intervention. Epidemiologically, MAC is highly prevalent in our aging population. Its reports of prevalence is highly variable depending on the modality that was used to diagnose MAC, but it's roughly affecting 8 to 25% of the general population. It's highly age dependent, and with prevalence climbing over 60% in patients of those over age of 90. There's a strong female predominance and ethnic variation, with MESA study demonstrating highest prevalence in Caucasian, followed by Hispanic, African American, and lowest in Chinese population. So when we see a patient with severe MAC, you'll often see this kind of patient in this picture, a Caucasian elderly female, somewhat obese, with multiple comorbidities, and living a sedentary lifestyle. The the etiology of MAC is multifactorial. Numerous studies have found a significant overlap between atherosclerosis, a risk factor with atherosclerosis, including age and smoking and diabetes, hypertension, and hyperlipidemia. Interestingly, mechanical stress to the mitral valve annulus is also thought to play a major role. So disease that affects mitral valve apparatus, such as aortic stenosis, or causes tension to the mitral valve apparatus, such as aortic stenosis or hypertrophic cardiomyopathy or mitral valve prolapse, has been associated with progression of MAC. It is also very commonly seen in chronic kidney disease and dialysis patients, and some studies have found that loss of calcium phosphorus homeostasis, particularly when the phosphate levels are elevated, it serves as a fuel that derives deposition of ectopic calcium within the heart. And then female predominance, especially after age of 50, suggests that postmenopausal osteoporosis likely leads to ectopic calcium deposition, including MAC. Also, female often has smaller LV, leading to higher wall stress and mechanical stress to the mitral apparatus that can further precipitate development of MAC. And then lastly, inflammatory process such as mediastinal radiation can also precipitate MAC, which in this case, typically it affects the air to mitral curtain rather than the typical posterior annulus. And it manifests about 10 to 20 years after exposure of significant radiation. Histologically, we now know that MAC is not just a passive deposition of calcium, it is actually an active cell-mediated process. Um, so chronic mechanical stress lead to repetitive microinjuries and creating a pro-inflammatory environment in the mitral annulus. And this triggers the resident myofibroblast to undergo osteogenic differentiation, uh, essentially turning into a bone forming cells. And these cells then begin active mineralization and deposition of hydroxyapatite crystals. And in advanced stages, this can progress to true ossification, where mature bone-like structure is found in the mitral annulus. And MAC is a metabolically active and progressive process. Once there is a baseline layer of calcium, it makes the annulus rigid and increase the mechanical grinding and stress on the surrounding tissue. And this injury triggers pro-inflammatory response, which then recruits more myofibroblasts to turn into osteogenic cells. So it's a vicious cycle, and the baseline calcium burden has repetitively found to be a strongest independent determinant of future disease activity and rate of progression. And this is a study elegantly looking at PET-CT of MAC using sodium fluoride, which is a marker of calcification activity, and FDG, which is a marker of inflammation, and found that in patients with severe MAC at baseline, there's increased calcification activity and inflammation, resulting in significant growth in 2 years, whereas in those with only baseline mild MAC, the calcification and inflammatory activity is low and does not progress too much in 2 years. Now, looking into the clinical consequences of MAC, MAC can lead to significant mitral stenosis, regurgitation, or frequently mixed disease. It is also a known risk factor for atrial fibrillation and conduction system disturbance due to proximity of annulus to the AV node, as well as calcium extension into the bundle of His. Beyond the valve, MAC is an independent predictor of stroke and myocardial infarction, and risk is proportional to the amount of calcification, which likely reflects kind of generalized systemic atherosclerosis process. Additionally, the irregular calcified surface may serve as a nidus for infective endocarditis, in which case Staph aureus is identified as a predominant pathogen in this situation. There is a specific variant of MAC called a caseous MAC, uh, and in this variant, the central area undergoes liquefaction necrosis and form a toothpaste-like core of cholesterol and fatty acid surrounded by calcium shell. And this is the actual picture here. On the echocardiogram, it looks like an echo-dense mass, which can sometimes be mistaken as tumor or thrombus or abscess. So we have to always have it in our differential. In case of caseous MAC, when you get a CT scan, it will show a hyperdense MAC with a center zone of lower attenuation. And it's usually actually have a benign course, usually does not involve mitral valve dysfunction, and can sometimes spontaneously regress, presumably because of erosion or rupture of the shells. But it has been associated with increased risk of embolic stroke if the outer calcium shell is compromised. And MAC causes mitral dysfunction through a unique geometric changes. As for mechanism of MAC-related mitral stenosis, the annular calcification itself can extend into and encroach upon the mitral valve orifice and displace the leaflet into the valve orifice and obstruct the diastolic transmitral inflow. The rigid calcification at the annulus can also reduce the diastolic annular expansion. And then finally, if the calcium extends onto the leaflet itself, particularly when involving the anterior mitral leaflet, this can restrict the leaflet motion, resulting in a stenotic physiology. As for MR, when the MAC extends onto the leaflet, this can result in restricted leaflet motion and impaired coaptation. Sometimes the posterior MAC extend underneath the posterior leaflet, which may push the posterior leaflet towards the left atrium and distorting the valvular geometry and reduces the coaptation too. The impaired annular dynamics due to rigid MAC can also contribute to MR, and finally, the atrial and annular dilation from often accompanied diastolic dysfunction and AFib can cause MR as well. And we must emphasize the difference between the rheumatic and MAC-related mitral stenosis. In rheumatic disease, it is primarily characterized by the commissural fusion, which results in this funnel-shaped valve with maximal stenosis being at the leaflet tips. In contrast, in MAC-related MS, usually the commissures are spared and the level of obstruction are closer to the annular level, and the leaflet is forming more of a tubular shape compared with this funnel shape. And why does MAC matter so much now? Well, the natural history of MAC is very poor. This is one of the landmark study defining the natural history of MAC, and you can see that compared to the age and sex matched general population, patient with MAC, regardless of degree of MAC, has significant worse survival. And this finding has been replicated in multiple studies, and that even after adjustment with traditional atherosclerotic risk factors, the presence of MAC is an independent predictor of mortality and cardiovascular events. And some studies have shown that the risk increases 10% for each 1 millimeter increase in MAC, so there appears to be kind of a dose-dependent relationship. This is another study looking at the natural history of MAC, focusing on progression of MAC and progression into mitral valve dysfunction. Here on the left is a graph looking at the proportion of patient progressing into severe MAC in 10 years, which was stratified by baseline MAC severity and sex. And you can see that only about 20% of patients with baseline mild MAC will progress to severe MAC in 10 years. But about 70% of patients with moderate MAC at baseline will progress to severe MAC, and there's a female patients appear to progress more. Here on the right is a graph looking at the proportion of patients developing mitral valve dysfunction due to MAC in 10 years. And you can see that it's pretty rare in baseline mild MAC, but conversely, very common in patients with baseline severe MAC. And again, it clearly shows that female has much more higher proportion of patients developing into mitral valve dysfunction compared to male. Now, thinking about the progression of MS and MAC, on average, mean transmitral gradient in MAC patients increased by 0.04 millimeter mercury per year. So in general, it looks like a very slow process. However, this progression can be much more rapid in certain subsets, such as high burden of MAC at baseline, active smoking, female sex, and chronic renal failure. And in patient with dialysis, the progression from mild to severe stenosis can occur over a much shorter time frame than in general population. And now I'll move on to the evaluation of MAC in general. This involves two things. One is the severity and extent of calcification itself, which is best evaluated by CT scan, and then the severity of mitral valve dysfunction as a result of MAC, which is primarily assessed by echocardiography. There are a couple of grading system and scoring system proposed by different groups regarding how to define the extent of calcification in MAC. And I just brought one of them here. This is again best assessed by CT scan. And this is one from the Mayo Clinic focusing on grading MAC based on its circumferential extent and extra-annular calcification, with grade 1 being less than half of the ring, grade 2 being 180 to 270 degrees, and grade 3 being larger than that. And these grading schemes are primarily important not for assessing the functional severity of mitral valve dysfunction, but for procedural planning when the decision is already made to intervene on the valve. For example, if the calcification is only mild, then they may be suitable for surgery. Whereas if it is severe, they may not become suitable for a surgical candidate, but may become a candidate for transcatheter mitral valve replacement, since the extensive calcification can actually serve as the landing zone to anchor the valve. So CT is now considered more of a mandatory to determine the modality of intervention, as well as sizing of the valve and risk prediction after TMVR. Now, when we try to evaluate the severity of mitral valve dysfunction in MAC, echocardiography is obviously the go-to method, but there are many challenges. Oftentimes, MAC causes severe acoustic shadowing, as in this picture, which makes it hard to especially evaluate the MR. Also, all the metrics to evaluate the mitral stenosis is developed for rheumatic MS and is not validated in MAC-related MS. And often, a concomitant valvular abnormality and myocardial dysfunction further complicates the quantitative evaluation of mitral stenosis. So really, multi-parametric approaches are recommended. This is a summary slide of the methods to evaluate the severity of MS, including planimetry, pressure half-time, continuity equation, pressure gradient, and how each of these methods can be inaccurate in patient with MAC, which I'll go through a little bit in details in the next few slides. As for reference, severe MS is currently defined as mitral valve area below 1.5 and corresponding mean gradient above 5 to 10, but this too has been extrapolated from rheumatic MS population. The planimetry is probably the most reliable echocardiographic method to quantify the severity of MS because it does not involve any hypothesis regarding flow conditions or cardiac chamber compliance or associated valvular lesions. However, direct planimetry by 2D echo is often inaccurate because MAC-related orifice is often non-planar and located near the calcified annulus where there's a lot of acoustic shadowing. So in order to obtain an accurate planimetry, the TEE with multiplanar reconstruction, as in this picture, is needed to precisely align the imaging plane orthogonal to the true minimal orifice. This is the continuity equation using the LVOT VTI and mitral valve VTI and LVOT area. And I think it's one of the more robust because it's not affected by chamber compliance. However, it's important to note that it cannot be used when there's a moderate or greater MR or AI. It can become unreliable when there is irregular rhythm like atrial fibrillation because it relies on stroke volume, most of which is very commonly present in MAC population. Furthermore, in MAC population, accurate LVOT diameter measurement may be challenging when there is severe calcification at the aortomitral curtain, for which this limitation can be overcome by using dimensionless index, which is simply using the ratio between the LVOT VTI and mitral valve VTI. The pressure halftime we should avoid using in MAC-related mitral stenosis because it's highly dependent on LA and LV compliance. And patients with MAC are usually elderly with lots of comorbidities and most unanimously have reduced LA and LV compliance. And this is a classic LA and LV hemodynamics waveform that you'll see in MAC and rheumatic MS. Now, in MAC-related MS, you can see that there's usually a very very tall V waves that reflects the reduced LA and LV compliance, characteristically with rapid decline in Y descent. And this on echocardiography is seen as a tall mitral E wave, but a rapid E wave deceleration. So longer pressure halftime. So if we rely on the pressure halftime, we systematically overestimate the mitral valve area. This is different from rheumatic MS, where Y descent is less steep due to impedance of LA emptying by the funnel-shaped mitral valve. And then finally, the Hadel formula, which estimates mitral valve area by dividing 220 by pressure halftime, is only validated in rheumatic MS population and not validated in MAC-related MS. And I think transmitral mean gradient is one of the more practical measurements and we discuss this a lot in the clinical setting because it's easy to acquire, but also has some notable limitation. One is that it's also heavily affected by the LA and LV compliance. And as we discussed in the hemodynamics on the prior side, the elevated E wave from reduced LA and LV compliance can increase the mitral gradient independent of the actual stenosis of inflow, which again can overestimate the severity of MS. It's also flow dependent, so it can be affected by factors like heart rate, stroke volume, MR, or anemia. So a lot of limitations for transmitral gradient, but having said that, the mean gradient is one of the most powerful prognostic marker in MAC population. This is a study focusing on MAC-related mitral valve dysfunction and elegantly shows that increase in transmitral gradient is clearly associated with increased mortality. This panel A stratifies patients by control group, mean gradient 3 to 5, 5 to 10, and above 10. And there's a graded increase in mortality. The panel B here is a spline curve with mean gradient on x-axis and adjusted hazard ratio on the y-axis and clearly shows almost a linear relationship. And this is all after adjustment of relevant clinical variables as well as heart rate. And interestingly, they further stratified each group by severity of MR and showed that concomitant MR is associated with excess mortality in low gradient range, but not in the high gradient range, indicating that there's a prognostic utility of transmitral gradient in MAC-related mitral valve dysfunction, regardless of MR severity, when the mean gradient is higher than 10. Now I'll go into the management of MAC-related mitral valve dysfunction. Quickly looking at the guidelines, both the American and the European guidelines section regarding mitral stenosis predominantly discuss about the rheumatic MS and mention about the MAC-related MS is extremely limited. Both of them just briefly gives this only class 2B recommendation for valve intervention in severe symptomatic patient with severe MAC-related mitral valve dysfunction, which kind of reflects how novel the field is and how limited available data remains. Just for sake of completeness for myself, for in Japanese guidelines, they just mentioned that MAC causing mitral valve dysfunction is extremely rare, make no recommendations whatsoever about MAC-related MS. This kind of reflects how low the prevalence of MAC-related mitral stenosis is in the East Asian population. Medical management remains the mainstream of care, including aggressive diuretic, strict heart rate control to maximize the diastolic filling time. Patients also often have a concomitant phenotype of HFpEF, so evidence-based therapy for HFpEF, such as SGLT2 inhibitor, can be considered. And in patients with MAC-related MS and atrial fibrillation, we don't have any data to guide on warfarin versus DOAC. And we know that for rheumatic MS and AFib patients, warfarin was better in the Invictus trial. But whether that holds true for MAC-related MS is unknown, and guidelines do not specify about MAC-related MS population. Now, surgical intervention for mitral valve dysfunction in patients with severe MAC is known to be exceptionally challenging. Usually, first of all, they have a high surgical risk to start with due to advanced age and multiple comorbidities. And in addition, this is a picture of surgery where calcium is basically chiseled out and the annulus is reconstructed. But this maneuver carries a significant risk of AV groove disruption and injury to the nearby structures, including circumflex arteries or coronary sinus or the conduction system. There are strategies they call the respect strategies, where they respect the calcium, meaning they minimize the decalcification or debulking of the MAC. But it then carries a risk of PVL due to suboptimal suture line. The apposition of the valve is not well, and the patient-prosthesis mismatch can occur due to smaller valve being implanted. And these risks, combined with patients' frailty in this population, lead to operative mortality rate as high as 14%. These are There are these hybrid approaches that has been tried, in which surgeon opens the left atrium, then deploys a transcatheter sapien valve, which is a TAVR valve, under direct vision. And this offers a theoretical advantage that it can eliminate the need of aggressive debulkation of calcification. Uh, they can resect the intermitral leaflet to prevent LVOT obstruction. They can uh, suture the valve to the atrium that prevents migration. And it also often results in larger effective orifice area compared with surgical prosthesis. However, this approach has still been reported to have a very high short-term mortality, unfortunately. Now, in the transcatheter intervention era, we have more approaches that are less invasive and potentially available in this population. For patients with predominant MR, the edge-to-edge repair like MitraClip has been reported, but it requires a careful patient selection, including the leaflet graspability, and it cannot be performed in patients with high grading to start with because it will worsen the mitral stenosis. The transcatheter mitral valve replacement is an option in these patients, and at Emory, we're very high volume centers in the country. So we have the privilege of taking care of these patients after TMVR. So I'll be discussing a little bit more in details in the next few slides. And then lastly, the lithotripsy assisted valvuloplasty is a more of a approaches that have been tried in patients who cannot get transcatheter mitral valve replacement and has been reported in small case series. The most data in TMVR currently comes from off-label use of sapien aortic valve platform in the mitral position. It's called a valve and MAC. It relies on the circumferential MAC to encounter or to anchor the valve. And unfortunate fact is that, as shown here, this is somewhat of an older data and outcomes are better now. But we can see that valve and MAC population have a significantly worse outcome and challenging compared with valve and valve TMVR. And the main risks include LVOT obstruction, the PVL, and the hemolysis. Uh, and Emory has been really the pioneer in developing techniques to prevent these complications, and I'll explain it a little bit in details later. Just briefly touching on this, there are some dedicated devices are becoming available now. The tendon valve here is a transapically delivered device with anchor at the apex, looks like a parachute. This became available last year. The M3 valve is here. It's a transceptor delivered device. It has this characteristic docking system to anchor the device. This was just recently approved by the FDA, so we're starting to see more of this soon. Um, as we briefly touched on, the main complications of transcatheter mitral valve replacement is this LVOT obstruction. So when the transcatheter valve is implanted in the mitral position, the native anterior mitral leaflet is pinned open to cover the stent struts, resulting in like a cylinder protruding into the LVOT against the interventricular septum, which risks the LVOT. And from the early experience using the Sapiens 3 device, this occurred in about 40% in valve and MAC TMVR population, and the associated mortality reaching up to 50%. I'm not going to go too deep into this, but we use CT analysis to predict this complication where we basically virtually implant the valve and measure the area of this new LVOT. When they meet a specific criteria, we determine that the risk of LVOT obstruction following TMVR is high. There are several approaches to mitigate this complication. Um, I go s- brief I'll briefly go through them because we will encounter these cases at Emory when we see the procedure films and reports of patients who underwent TMVR. Um, This is a lampoon procedure where basic concept is that it uses transcatheter electrosurgery to cut the anterior leaflet immediately prior to the TMVR device so that, as in this picture, blood can go through the LVOT through the stent struts. Sesame is another approach, tries to tackle the same problem through different approaches. um, Basically creating more of a space in the LVOT through septal reduction. This is a cartoon here which shows the procedure steps in which the catheter is engaged in the basal septum, and through this a stiff guide wire is advanced intramyocardial until it re-enters the LV cavity, and then it is used for transcatheter electrosurgery to split open the septum and relieving the LVOT obstruction like this. Um, the PVL and associated hemolytic anemia is another main complication of valve and MAC TMVR, which happens because of the complex calcification interacting with the transcatheter valve. We use this procedure called a Tootsie Roll technique where we deploy a Viabond stent in the PVL tract and deploy a vascular plug inside it to seal off the PVL. And I just brought up these pictures here because um, you might see this on the cast films and echo and might wonder what is that. In patients who TMVR was thought not to be anatomically feasible, such in the case that I presented at the beginning, there are reports of doing a shockwave lithotripsy assisted valvuloplasty. Shockwave lithotripsy is usually done in peripheral vasculature and coronary when there's a lot of calcification, but it's been extrapolated and used in MAC population. It's been reported in small series and effectively have shown that it creates a microfracture of the MAC and allowing reduction in gradient. This is a publication that was just published a month ago looking at the cadaver of MAC and looked at the CT before and after performing the lithotripsy, and it shows that there was a successful creation of calcium fracture and fragmentation. Lastly, in the next few slides, I'll discuss some unresolved conundrum in MAC-related mitral valve dysfunction, particularly when deciding who to intervene on and when. First is that patient with MAC-related mitral valve dysfunction often has a concomitant diastolic dysfunction, making it difficult to determine whether their symptoms are primarily driven by the valvular dysfunction or underlying ventricular diastolic dysfunction. This figure again illustrates the hemodynamic comparison between a patient who had a mitral stenosis and MAC-related mitral stenosis and underwent intervention. In both cases, the echo showed that the mean gradient was about 12 and the invasive LA pressure was about 27 to 28. Now, in patients with rheumatic MS, the valvuloplasty led to dramatic reduction in both mean gradient and left atrial pressure. Now, in contrast, in this patient with MAC-related mitral stenosis, TMVR resulted only in modest reduction in mean gradient, and there's a persistently elevated or LA pressure and tall V wave, reflecting a significant contribution of diastolic dysfunction rather than the valvular disease. And currently, it remains very challenging to predict this distinction before intervention, and developing methods to better identify those patients who benefit from TMVR is an important unmet need. In that regards, we were looking into our patients who had sesame prior to TMVR to prevent LVOT obstruction. And interestingly, found that about 50 to 60% of patients who were thought to have severe MS and had planned for TMVR and had this sesame done, 50% of patients had symptom improvement with sesame alone. And we were thinking that these patients might have had symptoms more from diastolic dysfunction rather than the mitral stenosis, and that sesame may have alleviated the diastolic dysfunction by cutting through the circumferential myofibers. And finally, as we saw in our presented case, patients with MAC-related mitral valve dysfunction often are referred for intervention too late in the disease course to derive meaningful benefit. In the valvular heart disease literature, this is increasingly conceptualized um, concept using a stage model where which describes a progressive consequence of valve disease. So the process begins by isolated valvular lesion, followed by left ventricular remodeling, and then left atrial remodeling, which subsequently progress into pulmonary hypertension and functional TR, and ultimately leads to right ventricular dysfunction. And studies in MAC has also demonstrated a similar pattern where um, at more advanced stage have increased mortality. So when patients are in most advanced stage, intervention may be even futile, and we need to further study to elucidate who is the best and what's the best timing to intervene on. So as a take-home message, MAC is an active progressive disease independently associated with increased mortality and cardiovascular events. Assessing severity of MAC-related mitral valve dysfunction is challenging, and standard echo metrics often has limitations, and it requires multi-parametric approaches. The conventional surgery often carries prohibitive risk for many due to baseline comorbidities and technical challenges. And transcatheter therapies are emerging as a vital alternative, though achieving optimal outcomes requires further refinement in patient selection, this risk stratification, optimizing it of the timing of intervention, uh, and standardized technique to mitigate complications and device improvement. With that, I will finish my presentation and open up for any comments or questions.
Thanks, Hiroki. That was a very thorough review of MAC and all of the potential complications and things we can do about it. Like Hiroki said, we'll open it up to the group for comments and questions.
Hey guys, it's Vasilis Babalieros. Can you hear me?
Yes, we can
Yes,
hear
we
you.
can.
Okay. They're quite a journey. Hiroki, as always, incredible job. Hiroki did 2 years with us, research in the structural center, and it shows every bit of it when he gives these presentations. But MAC is something that we really have been digging in to at Emory because these patients end up coming, from all over the state without options, or even the Southeast or further. So we've had to learn a lot of these lessons that Hiroki has shown you the hard way, unfortunately. And sometimes I would say this is the one procedure that we do that the mortality and morbidity is quite high still, for all the reasons outlined. I think the best results we've seen have been when we address both the muscle and the valve disease, assuming that both are approachable, and they are not always both approachable, but those seem to be the best results. And very interesting that the Japanese guidelines say nothing to do, because that's what I was taught as a fellow, that MAC is not associated with mitral valve dysfunction. I think mainly because people just didn't understand it, or maybe, as you point out, in Asia, it's not very common to see, but it is a problem. The timing is a huge issue because patients feel okay or will slow down their activity until the very, very end, in which case it's usually very hard to reverse when the RV has dilated and there's pulmonary hypertension. It's very hard to reverse. But you'll see these patients more and more. There will be better therapies as we figure it out, but the small concentric ventricle with the left ventricle with the big RV, and the other concomitant aspects of atherosclerosis in the aortic valve and other places make these patients really, really challenging. Dialysis patients, I would say, would be by far the worst, because they have also the fistula that complicates their volume overload. But this is a very important topic, and I'm glad you covered it in so much detail. So just a bunch of comments, no questions, Hiroki, because we've lived this together, and I think for the other fellows and even for the attendings, to see this over and over again, it's, we rely heavily on CT now. The echo is just not enough. We need, multiplanar pictures, and the CT will get better with time, with photon counting and more details about the calcium. But great job, and quite a tour de force presentation, a lot of information.
Thank you very much.
Hiroki, Stan Sherman. Lithotripsy sort of scares me. The idea that you could have calcium flowing up to your brain. Is there some protection during lithotripsy of this?
Maybe Dr. Beverly knows a little bit more about this. I think in a lot of cases where we do intervention on mitral valve, when we worry about calcification, we sometimes do the sentinel devices. This lithotripsy is more of a very new uh, uh, kind of try, and it's only reported in several case series. But didn't really see any signs of increased stroke in those literatures. Um, but again, I think most of the time we'll do a cerebral protection device when we do these procedures.
All right. Well, if there are no other questions or comments for Hiroki, we'll give everyone a couple minutes back this morning. Thank you for coming, and we'll see you next week. And Hiroki, really great job.
Thank you so much.
Thanks.
The preceding program is copyrighted by Emory University.